So the next topic is cerebral palsy. It is permanent motor dysfunction resulting from non-progressive injury to developing fetus infant brain. So it is the abnormality which occurs by birth, most common disorder in children. It is multifocal etiology. There are different causes like prematurity, low birth weight. These two are the strongest risk factors. Other associated developmental abnormalities are preventricular leukomalacia, which include focal necrosis of white matter tracts. So it is associated with the development of periventricular leukomalacia, focal necrosis of white matter tracts. It prevents with It presents with upper motor neuron sign as the cerebrum is involved. So the signs we will get, these are the will be upper motor neuron signs like spasticity, hyperreflexia affecting greater than one limbs, greater than or equal to one limbs, persistence of primitive reflexes, abnormal posture, developmental delay in motor skills. Normal behavioral abnormalities, excessive docility, irritability. Its treatment include muscle relaxants, which is baclofen, botulinum toxin injections, which would lax the spasticity complaint, and selective dorsal rhizotomy. It can be prevented by prenatal magnesium sulfate for high risk pregnancies. So, how can we prevent this? We can prevent this by prenatal magnesium sulfate for high risk pregnancies. It decreases incidence and severity. So, the next page, yes, common cranial nerve lesions. Yes, very common nerve, cranial nerve 5, motor lesion. Jaw deviates toward the side of lesion due to unopposed force from the opposite pterygoid muscle. Jaw deviate toward the side of lesion. So if the right cranial nerve is 5th cranial nerve is damaged, then jaw would deviate toward that side due to unopposed force from the opposite pterygoid muscle. Cranial nerve 10 lesion. Uvula deviates away from side of lesion. So cranial nerve 10, the uvula deviate away from the side of lesion. So if we have the damage of right cranial nerve 10, the uvula will deviate towards left. So weak side collapse and uvula points away. Cranial nerve 11. Weakness, turning head to contralateral side of lesion. Sternocleidomastoid. Shoulder drop on side of lesion trapezius. So shoulder drops on the side of lesion. And cranial nerve 12. It is a lower motor neuron lesion. Tongue deviates toward the side of lesion. Lick your wound. So means tongue will deviate toward the side of lesion due to weakened tongue muscle on affected side. Bell's palsy. Bell's palsy is the most common cause of peripheral facial palsy. Usually develops after herpes simplex virus reactivation. Its treatment in glucocorticoid plus minus acyclovir. Most patients gradually recover function, but aberrant regeneration can occur. Other causes of peripheral facial palsy include Lyme disease, herpes zoster Ramsay-Hunt syndrome, sarcoidosis, and tumor, parotid gland tumor, and diabetes. So these are the feature of facial nerve palsy. You can see here the deviation and the dropping of mouth on the side of lesion. So this is the difference between upper motor neuron lesion and the lower motor neuron lesions. So in upper motor neuron lesion, the lesion is located in the motor cortex. Connection from motor cortex to facial nucleus in pons. This is the connection where the lesion can occur. Oh, sorry. So the lower motor neuron lesion. In this lesion, there is affected site of facial nucleus or anywhere along the cranial nerve 7. So affected sites, these are contralateral site and this is ipsilateral site. Muscles involved, lower muscles of facial expression, upper and lower muscles of facial expression, both are involved. Forehead involvement in upper motor neuron is paired due to bilateral upper motor neuron innervation, and in this it is affected. So other symptoms variable depends on the size of lesion, incomplete eye closure, dry eye, corneal ulceration, hyperacusis, loss of taste sensation to the anterior tongue. So these are the common symptoms which are involved. So the next one is neurology of ear, otology, auditory anatomy and physiology. You can see here this is the external here up to the tympanic membrane. So from the start of tympanic brain membrane up to this inner, you can say most medial bone of ear. This is middle ear, and from here we can see this inner internal ear or inner ear, in which we have vestibule, cochlea, seminal canals, etc. So we can see here outer ear, it is the visible portion of ear pinna. It includes auditory canal and tympanic membrane. So tympanic membrane is included in the external ears. Transfer sound waves via the vibration of tympanic membrane. Middle ear, it is air-filled space with three bones called ossicles, malleus, incus, stapes. Ossicles conduct and amplify sounds from the tympanic membrane to the inner ear, and after that this is a snail shaped, you can see this is a snail shaped fluid filled cochlea and contain basilar membrane that vibrate secondary to sound waves, and vibration transduced via the specialized hair cells auditory nerve signaling to the brainstem. So otitis externa, it is the infection of external ear, inflammation of external auditory canal, most commonly due to Pseudomonas. Thing to remember: Pseudomonas associated with water exposure, swimmer's ear. It is also called swimmer's ear. You can see here ear canal trauma, occlusion, hearing aid. These are all the risk factors that would result in external ear infection. Presents with otalgia that worsens with the ear manipulation, pruritus, hearing loss, discharge, malignant necrotizing otitis externa, invasive infection causing osteomyelitis, malignant necrotizing otitis externa, invasive infection causing osteomyelitis, complication of otitis externa mostly seen in older patients with diabetes, presents with severe otalgia and otorrhea. Otorrhea means discharge from the ear, and may lead to cranial nerve palsies. Physical exam show granulation tissue in ear canal. So otitis media, it is inflammation of middle ear, most commonly due to non-typable Haemophilus influenza. Streptococcus pneumonia, Moraxilla catarrhalis, associated with eustachian tube dysfunction, which promote overgrowth of bacterial colonizers of upper respiratory tract. So, it is associated with eustachian tube dysfunction, which promote overgrowth of bacterial colonizers of upper respiratory tract. Usually seen in children greater than 2 years old, presents with fever, otalgia, hearing loss. Physical exam shows bulging erythematous tympanic membrane that may rupture. Presents with fever, otalgia, hearing loss. Physical exam shows bulging erythematous tympanic membrane that may rupture. Mastoiditis, infection of mastoid process of temporal bone. Complication of acute otitis media due to continuity of middle ear cavity with mastoid ear cells. It presents with post-auricular pain, erythema, swelling may lead to brain abscess. So this is the end of this lecture.